Nutritional deficiency syndromes. Vitamin A deficiency may complicate disorders of fat malabsorption like sprue, biliary atresia, and cystic fibrosis and produces night blindness. Vitamin A excess can cause pseudotumor cerebri. Vitamin B1 deficiency occurs most commonly in chronic alcoholism, but may complicate other conditions associated with poor nutritional status, such as hyperemesis of pregnancy, malignancy, dialysis, prolonged intravenous feeding, or refeeding after starvation. Neurologic manifestations include Wernicke-Korsakoff syndrome, sensoromotor polyneuropathy, and optic neuropathy, usually retrobulbar. Treatment consists of thiamine therapy, 50 to 100 milligrams daily, administered parenterally if GI absorption is unreliable, as in alcoholics. Thiamine should be given before IV glucose or refeeding to avoid exacerbating the effects of thiamine deficiency in patients with unknown nutritional histories. Pyridoxine, vitamin B6 deficiency in children causes recurrent seizures refractory to conventional anticonvulsants. It is due to inadequate dietary intake or an autosomal recessive disorder known as pyridoxine dependency. It usually becomes evident within a few days of birth with severe seizures which cease after administering 50 to 100 milligrams of IV pyridoxine and requires lifelong supplementation of 2 to 30 milligrams per kilogram per day of pyridoxine. Pyridoxine deficiency in adults is rarely caused by deficient diets, but is caused by medications. The deficiency causes a sensoromotor polyneuropathy prevented by concomitant supplementation of 50 milligrams of pyridoxine by mouth per day. Pyridoxine overdose causes a sensory neuropathy characterized by diminished reflexes, impaired position and vibration sense, and sensory ataxia. Strength and pain and temperature sensation are relatively spared. Vitamin B12, cyanocobalamin deficiency, is almost always due to malabsorption. Causes include pernicious anemia, gastrectomy, ileal diseases such as tropical sprue, regional enteritis, and bacterial overgrowth, and rare inherited metabolic conditions. Neurologic manifestations include subacute combined degeneration, that is, a myelopathy involving the posterior columns and lateral corticospinal tracts, dementia, sensoromotor polyneuropathy, and optic neuropathy, usually retrobulbar. Laboratory evaluation includes complete blood cell count, serum levels of cyanocobalamin and folate, urinary homocysteine, and methylmalonic acid levels, and the Schilling test. Treatment consists of IM injections of 100 micrograms daily or 1,000 micrograms twice weekly for 2 weeks, followed by weekly injections of 1,000 micrograms for another 2 to 3 months. If the B12 deficiency results from malabsorption, the patient should be placed on lifelong maintenance therapy of monthly 1,000 microgram injections. Oral repletion may also be effective if GI absorption is normal. And that is nutritional deficiency syndromes. Have a great day.